Hi, I'm Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm talking today with Dr. Meagan Grega, a family physician in the Allentown, Pennsylvania area, who is co-founder and Chief Medical Officer of the Kellen Foundation. This is my second opportunity to be talking with her. She's part of a group of family physicians who are beginning to come together to talk about how we can advance the lifestyle medicine movement, moving from highly innovative area into more into the mainstream, so that more people and more communities can benefit from the knowledge and skills that Dr. Grega and others have. Dr. Grega, thank you for joining today.
Oh, thank you so much, Larry. I really appreciate it. And I am so glad that you invited me back to talk about this, because you know this is one of my big passions. So I would love to share this with all of your listeners, and especially with all of the residents and medical students that are interested in family medicine, because I think this is one of the things that really speaks to the heart of why we went into family medicine in the first place. And I think there's more and more opportunities to do this type of work, both out in the community and in our clinic. So thank you.
That's a very good point. And I think not everyone appreciates why people choose family medicine. And I do think it is a choice. It's a sense of calling. It's a sense of calling to help people, help communities, to promote healing. And there's a great deal that's going on in our healthcare delivery system right now that actually undermines the call to healing. And one of the things I'm excited about with the lifestyle medicine is it's really back to not the basics, but the core idea of why family medicine was created in the first place. Mm-hmm. So, Dr. Grega, Meagan, could you speak to that? And what are your thoughts about why you think lifestyle medicine has the attraction that it does to so many in family medicine, and of course beyond, but especially in family medicine?
Absolutely, because I feel like as family docs, we're in perfect position for this type of medical, I don't even want to say intervention. It's really like a relationship, this medical relationship over time, because we see people over their lifespan. You know, we definitely deal with acute issues, that's true. But the whole goal, I think, of family medicine is building that relationship with the patient, a lot of times with the whole family, and helping them live their best life. I always talk about, you get dealt a certain hand of cards, but how can you play it the best possible to win the game, or to do the best you can? And that means that prevention is very, very important, but so is the treatment of any chronic diseases. And we can help support, encourage, educate, and really get people to kind of move down the path of healthier lifestyle choices, which is much more effective than just treating them with medication. So I know we're going to be talking about a lot of different lifestyle medicine type of pillars today. I don't want anybody to come away from this conversation thinking that I mean no medicine, like that we never treat people with medicine, because sometimes that's necessary. You might need to treat high blood pressure, high cholesterol, diabetes, heart disease with medication, but we should be looking at their lifestyle choices as the foundation, as one of the first things that we try to work with, because that's going to give us a whole lot more kind of bang for our buck. And also they're going to feel better in the long run, because luckily with lifestyle medicine stuff, the only side effects are good ones. You don't have any of the unfortunate side effects that we sometimes get with medications or procedures or things like that. So I feel like family docs are really called to be, like you said, to be healers, to be a part of the community, to be a part of their patients' lives over the long term. And that's really what lifestyle medicine is about, is teaching people how can you, like, your health is in your own hands in a lot of ways. So how can you make the choices that work for you? Because the same thing doesn't work for everybody. You know, this is not a one size fits all approach. But what works for you, what works for your family, so that you have the best chance of having a long, like what I like to call a lifespan, but also a long health span, that you are healthy for the majority of your life. You're able to be active and vital and do things that are important to you. And that the part of your life that has more chronic disease or maybe some morbidity in it is as short as possible. One of my lifestyle medicine mentors says, I would like to die young as old as possible. So like, I'm still a young person. I'm still able to do a lot of things. I've just made it as old as possible to do that. And I think that resonates with family docs, because that's why we are called to take on this profession, as opposed to some of the other medical professions that are very important, but are not quite as relationship based over the long term.
So I had the opportunity a few years ago to travel to Greece, and we ended up on the island of Kos, home of Hippocrates. And after the Hippocratic Oath renewal ceremony, which was really a pageant, it was really quite powerful, we went to the Hippocratic Institute. And I tell people I was radicalized by Hippocrates. When I read of the approach to medicine and surgery that they had, everyone focuses on Hippocrates in terms of eating, how they promoted healthy eating, but they also had surgery and had surgical instruments, and those were all laid out there. And they had incredible knowledge that they had, healing knowledge that they had developed. And it really struck me as I began thinking about lifestyle medicine, how much lifestyle medicine is a return to the roots of Western medicine in the Hippocratic tradition. Could you comment on that?
Well, it's interesting that you talk about going to Greece, because that makes me think of the blue zones. And the blue zones are places in the world that are like longevity hotspots. It's places where that have the highest percentage of centenarians and older, even older than centenarians on the planet. And there's one in Greece. It's called Ikaria. It's the island where people forgot to die. That's what they call it. And I know, right? That sounds like a good place to go on a vacation, doesn't it? So there's one in Ikaria, Greece. There's one in Sardinia, Italy. There's one in Okinawa, Japan. There's one in Costa Rica. And there's actually one in Loma Linda, California, the Seventh-day Adventist population there. And the thing about the blue zones is exactly what you're talking about Hippocrates and kind of going back to the real basis of Western medicine, is that these are places in the world where people live very, very long, longer than most other places in the world, even though they have less access to healthcare, except for maybe Loma Linda in California. They spend way less than we do on healthcare every year. And so when they first found these blue zones, they sent a whole bunch of researchers to go say, like, what is it? Is it like their genetics? Is it something in the water? Is it, I think they were looking for a supplement or, some sort of pharmaceutical, something that they could spread around the world. But what they found is it was really the lifestyle that these communities support. And this plays into one of my big passions, or one of the things I like to teach people, is that what choices we make every day have a huge amount to do with the social norms that surround us, what everybody else is doing. We're very likely to follow along with what other people are doing in our community or our family or our friends. And also the choice architecture of what is going on in our community, which is choice architecture is what is your default choice? What is almost like you, without thinking about it, that's what you end up doing. Like in most of our communities, the default choice for us right now is to get in our car to go someplace, for example. So in the blue zones, they have a completely different choice architecture and different social norms. People grow up in those communities basically being physically active, not going to the gym, but they have daily, regular, just kind of low intensity, moderate intensity activity because they're walking around to go to the market or to do their jobs. They also follow a predominantly whole food plant-based diet, not completely vegan. And I would like to actually take this opportunity to talk about those terms, because when people hear vegan or when people hear low fat, that gives them an idea of a certain diet. But I don't really like those terms, because vegan and low fat are basically just saying what you don't eat. And so in vegan, it's all animal products. You don't eat any animal products. For low fat, it's that you're eating a lower percentage of fat than the standard American diet. But there is a lot of unhealthy vegan and low fat junk food out there. So you could technically be vegan or low fat and still not be eating a healthy diet. Whereas whole food plant-based means, what are you eating? It really refers to what sort of things are you eating. And a whole food plant-based diet is really focused on plant foods, but ones that are unprocessed or minimally processed. So not having extra added sugars or a lot of processed oils or things like that. So it'd be stuff like fruits, vegetables, nuts, seeds, whole grains, definitely beans. Legumes are a big piece of it. And that's what they're doing in the blue zones, is that type of dietary pattern. Not 100% whole food plant-based, just predominantly whole food plant-based. They still have maybe a little bit of meat, a little bit of cheese, little dairy, little stuff like that, but not frequently. It's maybe 5 to 10% of their diet over the course of, a week or a month. And so when they're eating that way, think of all the fiber they're getting and all the phytonutrients that they're getting, and what's that doing for their health. So in the blue zones, even though they would not call themselves vegan, or they would not call themselves anything really, they would just say, this is the type of food that I eat. They're eating a lot less processed food than we do here in the United States, a lot less sugar, and a lot more food as grown, things that are closer to nature as far as how much processing has been done. So the other things, though, that go along with what you're talking about in the kind of cradle of Western medicine, there's the food part, there's the exercise part, or physical activity, I should say, but there's also the social emotional part, which we often don't think about as much in medicine. I mean, we're getting better at that, I think, over the years, but how do you fit into your community? What's your sense of purpose? Do you have somebody or a group of people that you feel would support you if you needed help? And that's another big piece of the blue zones, is that sense of purpose, that sense of belonging, that sense of kind of like working for something bigger than yourself. That actually is a very, very important predictor as for people for their longevity in the blue zones, but also here in the United States. So when we look at our lifestyle habits over time, things like what we eat, how we move throughout the day, how much sleep we get, and sleep is really an important piece that we haven't touched on much yet, but that's another critical piece that in American culture, we kind of give short shrift a lot of times. But then also, how do you feel about your life? What's your purpose? What gets you excited and passionate to get up in the morning? And do you feel like you're a part of a supportive tribe or family? That's the sort of thing that I think you probably were feeling or seeing on the island that you were at in Greece. And that's the type of rhythm that goes through the life of people that live in the blue zones. So as far as I'm kind of thinking about what I would like for my life, I want to make a blue zone around me, right? Like, who doesn't want to have this longevity, long lifespan, long health span? But it's something that we need to do as a community to make it as available as possible for not just a few people in the community, but that's the social norm of what we're used to having in our community.
Sorry, had a little interruption here on my end. So could you speak to one of the issues that strike me, with so much of medicine these days focused on the pharmaceuticals, taking a pill to fix a problem is a relatively simple and easy thing. You don't have to get all that motivated most times. You're taking it once or twice a day or whatever. Making the changes in how, not only what one eats, but how you talked about, their whole approach, let's call it their philosophy of life. What's your thoughts about the challenge for many people who have a hard time making these kinds of changes, particularly in the culture that we have, whether it's they're watching TV or reading newspapers or whatever, that's emphasizing so much of the fast food, a lot of sugar, those kinds of things. What's your approach, and how do you work with patients to help them make that real change in how they think about their food, their nutrition, their activity, etc.?
Absolutely. You bring up a perfect point, because this comes up quite a bit when we start talking about lifestyle change in audiences in general. And so the kind of like prevailing thought is that, well, it's easier to take a pill. And it is probably easier to take a pill. But when you look at adherence rates for the medications that we as family docs prescribe, for example, they did a study looking at after an acute MI. So people who had their first heart attack, they were all, 100% of them, discharged from the hospital on a beta blocker, a statin, and an ACE inhibitor, which we would probably all agree that that's good therapy. I would imagine they probably were put on an aspirin or something as well too, but the study did not look at that, but looked at those 3 medications and said, okay, you're supposed to be taking these. Within 18 months of their first heart attack, only 70% of those 100, originally 100%, only 70% of the patients were still taking the medications. So 30% had stopped entirely, even though it was just, taking those pills. So part of, well, no matter what we're asking our patients to do, whether it's lifestyle change, whether it's taking a pill, whether it's, anything, the relationship is the key. You need to be able to continue following up and, goal setting, motivational interviewing, finding out how things are going with that particular patient and what are their roadblocks and how can you help them surmount that. So when we think about lifestyle change, a lot of people are like, oh, that's much harder. But they did another study that looked at participants who went through something very similar to something that Kellen Foundation helps to run. It was called a CHIP program, which is Complete Health Improvement Program. They looked at these patients who, now it was a more intensive intervention. The patients had contact with their healthcare provider for several sessions over a 3-month period. So it was not just a here's your script and go. It was a whole relationship of changing things and feedback and group support. But they looked at those people 18 months later to find out how many of them were still doing the activities, physical activity, for example, like how many steps a day. They were looking at step counts, and also things like calories, how many calories were they eating a day, and had they followed the initial recommendations of increasing their fiber intake, increasing their vegetable intake, decreasing saturated fat, and decreasing processed sugars in their diet. And if you looked at after 18 months, between 60 and 80% of the patients were still doing those lifestyle changes, depending on which one you're talking about, physical activity or calories or things like that. So that's almost the same. It's almost the same type of adherence as the medication. But what we have to think about as a healthcare system is it takes more time. It takes more physician or health coach or nurse practitioner or what. We need to have relationships with the patients. You can't just give them a script that says, go home, exercise more, sleep better, stop eating so much junk. Like if you do that, it's not feasible for them to follow. But if you go through a process of education, group support, and individualized goal setting, which is also very important, you can find results like we found with one of our actually during the pandemic, during one of our most recent complete health improvement programs that we do. Kellen kind of wraps around a lot of extra food as medicine with our CHIP program. So we actually bring whole food plant-based meals to the majority of the sessions. So people eat dinner with us. They get to taste the recipes and realize that they really love it and that they are happy to cook it at home. We do some physical activity together, stuff like that. So it's like reinforcing the habits. But we started out with our participants in January 2020 before COVID hit. And then we got a good group vibe going, but then we had to transition to virtual because of the pandemic. But we kept everybody together, the kids, now the participants together. I'm thinking of my elementary school kids here. And after 5 months of the intervention, they actually, over 90% of them had lost weight, even in the middle of the pandemic, when most people in America are facing the dreaded quarantine 15 that they gained. And over 70% of them actually lowered their systolic blood pressure, and about 65% of them lowered their diastolic blood pressure. And that was over a 5-month intervention that had nothing to do with medication. It just had to do with changing eating habits, exercise habits, ways of dealing with stress, things like that. So we're excited to see these guys again in about a year and do those changes stick. That's important. But I think it's also important for us as family docs to realize that behavior change can be just as powerful as medications, and it can be just as long lasting. It's just you need to put in the initial preload work of helping people make this a part of their new life.
So those are some very impressive results. And the thing that I think about is that, we've developed a culture, especially in this country, but also in other parts of the Western world. We've developed a culture where people from the time that they're born, they're enculturated in a certain way of eating, certain way of thinking about food, a certain way of thinking about activity. And until we've changed the dominant culture, so to speak, it's always going to be somewhat of an uphill battle to help people make those kinds of sustainable changes. But the other thought that I have is that because of our current RV, you get paid based on how much you do, your activity-based payment systems. It is difficult to do things like group visits. They can be done. As a social worker, I know the value and power of groups and being able to see people in groups. I think you referenced that in one of your comments a little while ago. But being able to really create a community of support that surrounds the individuals and helps them move forward, I think is an important element in the overall strategy. Your thoughts about that?
Yeah, absolutely. And that's part of why so much of this type of work, this lifestyle medicine work, can be done initially in the clinic. You know, that's where we would maybe start these conversations, but we also need to be out in the community helping to create these like supportive pods, kind of what you're talking about. So for example, the CHIP program that I referenced, that was done at a workplace. So it was an employer who had said this was a good idea for his employee, well, it wasn't his, but like the employer said this would be a good place for a program. So these were all people that worked together, which meant that they then were acting as a support system for each other as they were going through these changes. So some of them put together a walking club at lunchtime before the pandemic made them stop, you know, and a lot of them would show each other what they brought in for lunch, or they were sharing recipes. That's a very effective way to kind of, it's like, oh, we need to do smaller thinking than we currently do in medicine. A lot of times we're like, here's a recommendation for the entire United States. Let's do it this way. It's very community and place-based. So like, where can you find a group of people that are already a little bit of a tribe? We use elementary schools quite a bit because that's often a kind of like a hub for a community. The PTAs, the staff that work there, the teachers, the janitors, all that, because that's a place where people already come together and they spend time. Churches or other religious institutions is another great one. YMCAs, senior centers, like we do senior centers as well, because here's people that are already sort of a group. Maybe they don't know each other that well yet, but you know, they're around each other. And now they can help support each other in these lifestyle changes. The other key thing is to get the families involved. So for example, with the CHIP program that I was just recently talking about, we invited all the family members to come as well. So it wasn't just the employee, it was, they could bring their spouse. A few of them actually brought their children, you know, and they just kind of kept them occupied during the time. But that's really important because then you're getting the buy-in from the people at home as much as the people that you're maybe around during the day. So I think what we have to start thinking about as we're shifting our payment models in this country, because we know that the way that we are currently financing healthcare is not working for us, because the United States spends almost $11,000 per person every year on what we really should be calling sick care, not healthcare. And that is way higher than any other of our reference nations throughout the world. So and yet we have some terrible mortality statistics. We're not doing so well as far as our rates of diabetes and heart disease and obesity compared to other countries. So we're not getting a good return on investment. That's what I would like us to think about. Not that like, oh, we need to change to be more socialized medicine or anything like that. I'm not even talking about socialized medicine. I'm saying we're not getting a good return on investment. We're spending a lot of money and we still have a lot of these long-term chronic disease problems. So can we start shifting it so that we're putting some more money into these types of community-based, still healthcare, but more like where it's going upstream. You know, like if you talk about there's a story about somebody who is at the bottom of a river and keeps seeing, unfortunately, people, you know, drowning coming down the river, and they start trying to do something at the bottom of the river to save the people that are drowning, you know, and to try and like throw out life rafts or whatever. But then one smart person goes upriver to find out why are so many people drowning in this river, you know, what's going on up there, and finds that there's this big precipice that's by a walking trail, and people are falling off into the river. And that's why they put a fence up. This is not a true story. This is apocryphal, but they put a fence up, and no longer are people drowning in this river because they stopped the problem upstream instead of trying to save them when they're downstream. That's what lifestyle medicine is. It's going upstream and saying, how can we spend less resources, get better outcome by going out into where people live, work, and play, and helping them make these changes as groups because we're going to get better long-term outcomes, both from a health standpoint, but also from a financial standpoint.
So Megan, I hate to do this, but I'm going to have to call things short here because my battery is running out of juice. I thought I had a fully charged laptop here and I can't get a plug to it quickly. I'm wondering if there are any final comments that you might have for medical students or family medicine residents about incorporating lifestyle medicine into their future practice.
Absolutely. So just remember that lifestyle medicine, like we said, is not just about the food. The food is a part of it, but it's also encouraging physical activity, getting adequate restorative sleep, really supporting those social connections, nurturing those social connections, looking at stress management, and also avoidance of toxic substances like tobacco and excessive alcohol. So there is a lot of different options and things that you can talk about with any specific patient. You got to do the motivational interviewing piece and say, okay, where are they ready to make a change that might help where they're going? Maybe food is not where they're ready to make the change right now. That's cool. Are they ready to maybe start walking after dinner with their spouse? Or are they maybe ready to look at different ways to manage their stress that would be a little bit more healthy? So lots of options. But the other key piece I want you to think about is, as we want to be effective with the tools that we use, and one of the most effective things we can do is help people change their habits. The way we do that is by spending time talking with them. We may not have enough time. We almost never have enough time to do it all in one shot. So these are things where you start the conversation. I like to give patients homework, give them like a little YouTube video to watch, or a little thing to read, something like a book or something that's a video, and then have them come back and talk so that they're doing some of the work too. They're looking at some of the things that then you can come back and have a conversation that you wouldn't have had enough time to do in a single office visit. So realize that when you give the patients those sorts of informational little nuggets, they'll start thinking about it. They'll come back and want to talk to you about it. And that's what being a family doc is all about.
Dr. Meagan, Grega, thank you so much for, and by the way, have you heard about the million pound campaign, Meritus Health I'll have to send you information about that. So there's a hospital in Hagerstown, Maryland that has decided in their community that they're going to support an effort for the community to lose 1 million pounds.
Wow, that's great.
It is. And I was just the other day talking with their chief medical officer, actually their officer, a family physician who's director of population health. And this strategy is just brilliant. And we're going to be seeing if we can create a community of hospitals that will sponsor this for their respective community. So you'll be hearing more about this in the near future. But I think they've brought in the employers, they've brought in the advocacy organizations, and they've got a community-wide effort now that begins to address that whole issue of how do you build a culture around people that can help support the change that's needed.
That sounds fabulous. So see, there's lots of different things going on across the country. I think as doctors, we just have to kind of keep our eye on what's happening, not only in our office, but also out in the community, and then jump in and be an advocate and go out there and take a walk and put some food in the garden and talk to kids, talk to seniors, and eventually we will all be able to change the culture that we live in.
And thank you for being a family physician.
Thanks, Larry. I look forward to our next conversation.
You bet. Take care.